Hi, everyone. Welcome to this podcast exploring the timing of antibiotics and sepsis. My name is Katie Pendleton, and I'm your moderator. I'm really excited to be joined by some of the titans in the field today for this friendly debate. I'm pleased to introduce to you our two discussants, Dr. Stephen Simpson and Ryan Maves. Dr. Maves, would you like to lead us off?
Well, thank you very much, Dr. Pendleton, and thank you to Dr. Simpson and to everyone at CHEST for the chance to talk about this very important topic today. So we're going to be talking about antibiotics and suspected sepsis and about the relative timing of how soon is too soon, how late is too late. I'm going to be taking the cool your jets proposition today to talk about the need for restraint in the use of antibiotics and suspected sepsis, and then I'll be no doubt thoroughly thrashed by my good friend and mentor, Dr. Simpson, who will point out all of the errors in my reasoning. And of course, this is the three of us, somewhat more attractively posed. All right, so the scope of our problem effectively is that we know that delayed active therapy directed against the infection you actually have increases mortality in patients with septic, and particularly in patients with septic shock. This is a work here on the right by Dr. Anand Kumar and colleagues published in CHEST in 2009 that showed that patients who received inappropriate antimicrobial therapy, meaning therapy that did not target the infection they actually had a marked decrease in survival compared with those who received early appropriate active therapy. Next, please. On the flip side, we also know that increased antimicrobial use clearly leads to increased resistance. This is a meta-analysis of multiple observational studies that just shows that increased carbapenem exposure in patients in critical illness leads to an increased odds ratio up to 4.6 times greater than controls of developing carbapenem-resistant infections in the future. And this is deeply problematic, particularly with carbapenems. It's not as bad as it used to be, where we didn't have any effective therapies available for carbapenem-resistant gram-negative infections. We have a number of pretty good therapies now, but we're still not there yet. The other challenges we face is we have great difficulty distinguishing between bacterial, fungal, and viral sepsis at the bedside at the time of initial presentation, and there are delays intrinsic to culture-based assays. This is a picture of Fanny Hesse around 1881. Ms. Hesse was one of the first developers of the agar-based culture media, which is still 140 odd years later the basis of clinical microbiology to this day. And of course, in the background of this is the idea that some considerable amount, potentially up to 35% of patients with suspected sepsis presenting to emergency departments who receive empiric broad-spectrum antibacterial drugs do not have bacterial infections. So how do we do better? What can we do better with this to make sure that the people who need antibiotics early are getting antibiotics, and people who don't? Physicians are not necessarily that good at making these assessments at the bedside. This was a survey done by Dr. Chowdhury and colleagues published in 2016, where they took a series of cases of patients with, and this is using older definitions of sepsis and severe sepsis and septic shock, but took patients with various clinical scenarios and then surveyed practicing intensivists about whether they thought these patients had non-infectious SIRS or had true severe sepsis or true septic shock or none of the above. Case E, for those of you who can see the slides, is a slam dunk obvious septic shock case. And what you see is there is a widespread in how physicians interpret these cases. Now, granted, these are simulated cases. These are not with a real patient at the bedside. We may find different results if we're looking at someone with our eyes. But what it does say is that there's a great deal of heterogeneity in our ability to detect and diagnose patients at the time of initial presentation. Now, we all know, to the greatest extent that we can know, that the duration of hypotension before the initiation of effective antimicrobial therapy is the critical determinant of survival in human septic shock. This was demonstrated in an observational study, which is sort of the obligatory slide we all have to place in septic shock talks now, again by Dr. Kumar. But I think we all believe this is true, that the faster you get antibiotics into the patient, the greater your likelihood of achieving a good outcome. That there are very few modifiable risk factors at the time of presentation in septic shock, right? I can't change the patient's age. I can't change their diabetes. I can't change their CKD. I can change how quickly I recognize their shock and how quickly I get them treated. Now, what about the patients who aren't in shock? This has become a somewhat more contentious issue. What do you do with a hemodynamically stable patient with suspected sepsis? Is there an impact on mortality on delays? And this has been harder to tease out. In a study published a couple years ago by Dr. Stephanie Parks-Taylor, previously part of our group in Atrium Health in North Carolina, she looked at a number of hemodynamically stable patients presenting to our system's emergency department, and what she found was that delays in both recognition and delivery of antibiotics were associated in an observational manner with increased mortality. That if a person received an antibiotic order greater than 6 hours after ED arrival, that could lead to an odds ratio of death of about 1.2. And if the antibiotic was ordered and it took more than an hour and a half or so to get to the patient, that also resulted in increased risk of death. Now, there are a lot of confounding factors that can play into that, and it's not clear we can make a linear, truly causal association between delayed recognition, delayed administration, and increased mortality. But I think that does ring true with most of us, and I think that this study has a lot of validity on its face. I think we would all accept that those are probably pretty real numbers. So what do we know? We know that in septic shock, each hour without effective antimicrobial therapy probably increases mortality between 7 and 10% based on extensive observational data. I think we can also agree that this difference is less pronounced in the normotensive septic patient, although delays in recognition and administration may be linked with higher mortality. And we also know, and I think we all agree, that no one is ever going to be deliberately randomized to the delayed antibiotics and septic shock arm of the clinical trial, right? Observational data, high quality observational data is the best we're going to do here. And that's okay. That's okay. That's good. So knowing this, what's the problem, right? Like, why are we even having this discussion, right? It seems like there is a solid basis for unanimity. Well, what does surviving sepsis say? Surviving sepsis says antibiotics should be administered within an hour for patients with shock if sepsis is possible, if sepsis is a reasonable part of that diagnostic evaluation. Obviously, the patient with a clear massive GI bleed or clear cardiogenic shock, stories are different. And if patients do not have shock, might be septic and infection cannot reasonably be excluded, then you have up to 3 hours, right? Now, if a patient is clearly septic, even if they're hemodynamically stable, that 1 hour target still applies, right? If it is obvious the person has sepsis, treat them. Don't wait. So what are the things that are not controversial? It is not controversial that patients in shock should get early antibiotics if there isn't a clear alternative cause of their syndrome, right? I've given my share of vancomycin to patients who turned out to have cardiogenic shock upon further evaluation, right? I don't feel bad about that. I will do it again. Patients with obvious infections should also get early antibiotics if they have organ failure. Also, though, in the background, antibiotics are drugs, and drugs have toxicities. And we need to make sure we balance that risk, that toxicity of antibiotics, with ensuring that patients who are at the greatest likelihood of needing them are the ones receiving them. What are the mechanisms of these antimicrobial harms? I think we all probably basically know this, but it's nice to review. There's clearly the issues of antimicrobial resistance, that when we use broad spectrum antibiotics, we do provide evolutionary pressure. And this leads to increased risks for drug resistance, as is seen in clinical trials and in observational studies. There are direct toxicities related to mitochondrial toxicity with certain classes of drugs. Linezolid is the most widely used one in our current armamentarium that does that. Leukocyte dysfunction, lymphopenia, leukopenia, neutropenia, these are all predictable side effects of drugs like carbapenems. Anaphylaxis, cardiac toxicity in certain drugs, and then also the emerging area of microbiome disruption. Most of this attention is paid to the gut microbiome, but there is a very real lung microbiome as well. In my transplant infectious disease practice, I am very aware of the urinary microbiome in patients with kidney transplants. All of these things are the risk that we take when we expose patients to antibiotics. In septic shock, that risk is clear. That risk is clearly acceptable. What we have to do is figure out where do those lines cross in that risk profile? So what is the evidence of harm with inappropriate empiric antibiotics, right? A lot of the things I listed are theoretical. Well, there is good data to back up some of these. So in Lancet ID in 2011, this was in an earlier phase of the IDSA ATS guidelines. At that time, the IDSA ATS guidelines for the treatment of hospital-acquired and ventilator-associated pneumonia recommended empiric double coverage for for suspected gram-negative infections. And what they found was that in this study, that patients who did receive this guideline-adherent combination therapy had increased mortality compared with patients who received beta-lactam anti-pseudomonal monotherapy, right? That double coverage, that giving an extra antibiotic did not improve mortality. In fact, it did not improve mortality. In fact, it worsened mortality. In 2016, in JAMA Internal Medicine, Dr. Aranga and colleagues formed a randomized controlled trial looking at adult inpatients receiving 10 days of antibiotic therapy for community-acquired pneumonia versus 5 days. Patients who got 10 days actually had higher readmission rates than those who received shorter courses. Somewhat more recently, in Annals in Internal Medicine, Dr. Fagan and colleagues, this was in 2000, looked at patients receiving or undergoing invasive diagnostics for ventilator-associated pneumonia. So these patients had, I would say, a somewhat microbiologically better established diagnosis of pneumonia than by simple tracheal aspirate or simply empiric therapy. Those patients who had invasive diagnostics had lower mortality, which could be attributed, depending on your interpretation of the study, to decreased antibiotic usage, right? That their therapy was more targeted, more specific, and generally, in some cases, for shorter courses, although in 2000 practices were different. However, in this context of me arguing against antibiotics, I must make certain acknowledgments. One is that I owe Dr. Simpson a great deal, and I'm forever grateful to him for his friendship and mentorship. And as such, I would like to extend an olive branch as we proceed here. So let's, instead of talking about the things where we disagree, let's talk about the things where we do agree. My suggestions for compromise. Number one, we need to figure out a way to distinguish better in the intensive care unit between the potentially septic patient and the merely febrile patient, right? That is to say, I don't think any of us will be shocked to say that it's not uncommon for us to come on service and find a patient who spiked a fever the last night and has put on vancomycin or vancomycin or whatever. And that patient had improving hemodynamics, improving oxygenation, improving level of consciousness, but had a fever and was put on broad spectrum therapy for that. Now, while that's difficult to quantify in this context, I think we all agree that is a thing that happens. What I would challenge us to do is make that distinction. Focus more on the physiology, focus a little less on the fever. We need to get cultures first, right? Honestly, if you get good cultures and we give ourselves an escape hatch, if we have a mechanism to pull back antibiotics, I don't really care what you give in the first 48 hours as long as it covers the infection. If you think that vancomycin is what your crashing patient needs, fantastic, do it. But get cultures in advance so that we can tailor their therapy with more data as time arrives. The first 24 to 48 hours are not the problem. It's the first week, 2 weeks, 3 weeks of empiric therapy that is not got into cultures where we get into trouble. Double covering for gram negatives is usually sorcery. Our focus should be having a single active beta-lactam. If you need a second drug, I would say that second drug is probably amikacin. Right, if you think you need a second drug for empiric management of a highly unstable patient with a suspected gram-negative infection. And lastly, use shorter courses of therapy whenever possible. Modern antibiotic durations are largely the result of the work of Gudea, priest king of Lagash in the 3rd millennium BC. Gudea built a temple based on the 7 then visible planets in the sky, who reflected 7 principal gods of the Mesopotamian pantheon. That is the basis of the 7-day week, and thus antibiotic durations being multiples of 7. I think we can do better than that. And that's all I got. I'm going to turn it over to my distinguished colleague, and thank you again for the chance to speak to you today.
Thanks, Dr. Maves, for that great review. Dr. Simpson, the floor is yours.
Thanks, Katie. I'm happy to take over here. And my friend, Dr. Maves, has done an excellent job of carving out some areas of agreement here. And I will agree with him. You might find that I have a little bit of emphasis in a couple of different places. So as you see, I'm going, oh, what the heck are you talking about? Turn on the afterburners when it comes to getting your septic patients antibiotics. And by the way, I want to say this, Dr. Maves said something to me earlier about being outclassed in this argument. And this is proof, what you're looking at right here, that that's not true, because this is the photo that Dr. Maves took himself from an F-14 flying along through the sky. And I can assure you that outclasses anything that I've got to say
I think,
here on out.
To be honest, I think I was actually in an S3. I was just flying next to two F-14s.
Oh, gotcha. Okay, well, that's all right. I've never been this close to an F-14 myself. Hey, I want everybody to take a look at this thing here, and I will point out what I see on this thing. This is road rash, by the way. It's real live road rash. And what I see here is a couple of things. Look, if you're careful, you look around this area where the rash is, and you can see that there is cellulitis that I don't know right now whether it's advancing or de-advancing. But I can see that there's cellulitis and there are little pockets of pus here and here on this thing. So my question for you is this. If I told you that this person who's showing you the road rash had these vital signs of a pulse rate of 75, respiratory rate of 10, and a temperature of 37, what would you do for that? Probably not much. You'd probably say, keep it clean, keep it dry, perhaps cover it up so it doesn't get anything else in it. On the other hand, if I said, these are the vital signs in this person that is showing you the road rash, now what do you do? Well, I'll tell you what, I'm so sure that you did choose something different that I'm not even going to tell you what it was. I'm going to say, why did you choose something different there? And what I'm going to say is because you recognize that the latter circumstance, which is infection with a systemic response, is something more than a simple infection. And that's why you would behave differently. In fact, we have known for a long time, Hippocrates even said this, a local lesion heated by humor efflux makes the whole body become feverish. One can die because of this, especially on odd-numbered days. Now, that sounds funny to us, the odd numbers, the days, business, and I don't know where Hippocrates came up with that, but I'm going to give him credit because if you will remember, the reason that we look back to Hippocrates is because he was the first to actually try to make empirical evidence-based decisions about people instead of saying, oh, the gods have willed it this way. And by the way, I don't know what day you're watching this, but it's either an even or an odd day. So pretty soon you better watch out for what's coming. So let's go to our current definition of sepsis. I put that in quotes. It's a pretty good summary of sepsis, life-threatening organ dysfunction due to a dysregulated host response to infection. So when we're evaluating somebody, we need to assess for a couple of things. First off, we can't assess for dysregulated host response. In fact, there's plenty of reason to believe that the host response may in fact not be dysregulated. It may be behaving just as it's supposed to, but the consequences are just not something that we particularly like. Hopefully we'll come back to that in the discussion. So what do we need to look for when we're trying to identify our septic patients? We're looking for organ dysfunction and we're looking for infection. Now, organ dysfunction is relatively simple for us to identify. You know, we have some standard criteria. I think I may have said that on the next slide. No, I didn't. Oh, I know where I said it. I'm writing a paper about this right now, and I just typed it yesterday. Organ dysfunction is relatively simple to see, and we have some fairly standard criteria for that. Now, you can use the original Sepsis 1 criteria or the Sepsis 2 or the Sepsis 3 SOFA criteria. Any way you look at it, we have some pretty well-defined organs that we're looking for and criteria to tell us this is dysfunction. So that makes it easy. All we have to do is identify infection, right? Not as easy as you might think, and we're going to come back to that point. Now, Dr. Maves showed you this, which was the Anand Kumar slide showing the number of people that die as antibiotics are delayed. The one thing that I wanted to point out here, this was in 2006, you remember, is that only 50% of patients who were in septic shock got their antibiotics within 6 hours in that particular study. I don't think that happens in today's world. I think people, by and large, understand what Ryan said, which is that mortality is affected as you delay. People understand that. Plus, if you stop and think about it here, why would you delay? If you saw someone going into shock right in front of you, sitting in your ICU, which is what these people did, why would you delay the antibiotics? More than likely, it's because you're not sure that this is a new infection that you're going to treat. And it's only in the retrospective analysis that we figured that out. Now, it's not just in septic shock. This is data in 35,000 patients in Northern California from Vinnie Liu that shows the odds of mortality go up by 9% per hour of antibiotic delay, just with simple sepsis, 7% with severe sepsis, 14% for septic shock. This is people presenting to an emergency room. The New York State hospital data that was published by Chris Seymour and Associates analyzed 49,000 patients and showed the same thing, that the odds ratio for mortality went up by 4% for every hour that antibiotics are delayed. Here's data from Minnesota, where Dr. Pendleton lives, demonstrating that actually every aspect of the 3-hour surviving sepsis bundle has a time-based effect, and that antibiotics very quickly, delay in antibiotics is very quickly associated with an increase in mortality amongst that bundle. This is data that we published from the University of Kansas showing that people delays, if you come to the emergency room without septic shock, that delays in antibiotics actually increase your odds of developing septic shock. Now, and what we showed in the regression analysis was that the odds go up by 8% per hour of developing septic shock for every hour of delay from triage time until you receive antibiotics. Now, I want to point out something here, though. A lot of folks who disagree with me on how rapidly antibiotics should be given look at these bars and they go, oh, well, look, it's easy to see. It's easy to see that there was no problem up until about 5 hours. Here's the fallacy in that analysis. The regression analysis included 5 different confounders. The regression line is drawn for a least squares fit of all 5 of those variables. What you're looking at here is 1 out of those 5 variables plotted on the timeline. When you correct for age, sex, severity of illness, comorbidities, etc., we see that the incidence of septic shock goes up by 8% per hour. So we did this a few years later, took a look at not just people who showed up with severe sepsis in the emergency room, but what about people who just show up with infection, who are suspected of infection in the emergency room. And what we saw was that overall, about 7.5% of people who just have infection, suspected infection in the emergency room, will go on to develop shock, and that there are delays, and that the number of people who will develop septic shock goes up with every hour of delay. One of the criticisms of our previous study had been that we didn't look at severity of illness. So what we did to break that out here is looked at people who had QSOFA, people who had SIRS, and people who had neither of those things when they showed up to the emergency room. And obviously the people who were sickest, the people who actually have QSOFA on presentation, went on to develop septic shock more commonly. Interesting thing about all of these data, if you look down here on the bottom one, what this shows is cumulative percentage. And what we showed, which has been corroborated in other studies, is that people who got their antibiotics in the first hour still had a 40% risk of going on to develop septic shock. Or no, that's not the way to say that. The way to say that is 40% of the people who were going to go on to get septic shock did so even when they got their antibiotics in the first hour. And that's, we believe, because those people looked sicker. The people who look the sickest get the antibiotics the fastest, and that's been demonstrated in multiple different studies. So here's a question that I have for you. Most of you watching this podcast are pulmonary and critical care doctors, and I just want to ask you, do you believe that smoking causes cancer? Why? Why do you believe that? Have you ever seen a randomized controlled trial that demonstrates smoking causing cancer? My question for you is, how many observations of this type, all we've ever seen is observational data associating smoking with cancer, how many observations does it take before one accepts that antibiotic timing is important to prevent mortality and even death, morbidity, and even death in patients with infection? I'm not sure. So far, there are people who still look at the data I've showed you, plus 20 additional studies, and go, well, it's all observational, and we don't believe it. Now, what about the issue of antimicrobial resistance? It is real, and I respect it, and I want to be clear why I respect it. This is data from Archives of Internal Medicine, published in 1937. This is pneumococcal pneumonia and bacteremic pneumococcal pneumonia in 1937. When did we get penicillin? A couple of years after that, when it was discovered, and several years and a lot of years after that before it was readily available for the population to use. In 1937, if you got bacteremic pneumococcal pneumonia and you were 70 years old or above, you had an almost 90% chance of dying. Even if you were my age, between 60 and 69, you've got an almost 80% chance of dying. Those numbers have gone down substantially. In fact, after the advent of penicillin, the ratio of mortalities went totally the opposite way. Instead of 80-20 odds of dying, you had 20-80 odds of dying. But they have stuck there exactly like that for the ensuing ensuing 80 years, we'll call it. This is why I respect what it means to lose sensitivity to antibiotics and why we should be afraid. One of the key points that I would like to emphasize, I think, Ryan, you used at least a slide from the same study, but your mortality increases fivefold if you don't get the right antibiotic to begin with, which is why I'm going to propose, and Ryan and I can talk about this in a moment, that you start with broad spectrum antibiotics, certainly in somebody in septic shock. Now, the data that I showed you about progression to septic shock was also with broad spectrum antibiotics. So I think that we need to remember that if you don't treat the bug with something that's going to cover it, it's just the same as not treating it at all. So this is what I think about antimicrobial resistance and what to do. Be afraid, be very afraid, because as a guy who takes care of sepsis for a living, I can't do it if I don't have an antibiotic to do it with. So I am all for everything we can do with antibiotic stewardship to preserve the activity of our antibiotics. But don't let that stop you from initiating antibiotics quickly or at all. Let it push you to stop them when they're not necessary. And so you can see there's a slight emphasis, maybe a little bit of different emphasis, but by and large, I think Ryan and I are saying the same things. One of the points that I like to make, though, when we talk about antimicrobial resistance and how we perhaps shouldn't use antibiotics in various circumstances is this: who is it that we're saving our antibiotics for anyway? Is it for the 3-year-old with an earache and a fever? I don't think so. That's one of the big places where these things get abused. Is it for a 20-year-old with muscle aches, fever, and cough? Probably not. Is it for a 60-year-old with purulent sputum and fever? Well, maybe. But what about any of those if they've got mental status change and acute kidney injury or other signs of organ dysfunction? I think my point is that the whole reason that we're trying to preserve these antibiotics is because we literally care what happens to the septic patient. So yes, we do everything we can to preserve them, but I'm going to hold my course in this 3-year-old or this 20-year-old a lot more readily than I am in the 60-year-old. And I'm going to give them to any of these guys if there's organ dysfunction. Now, no randomized trial. Dr. Maves proposed that we'll never see the randomized trial to delayed antibiotics, but we do have this trial that's ongoing right now. Dr. Mitchell Levy at Brown University is running this study called the Assessment for Implementation Methods in Sepsis Study, or AIMS. It's cluster randomized by site, and sites are randomized to give antibiotics to septic patients within an hour versus within 3 hours to see whether faster is better than fast. That's all I have to say. You'll notice I borrowed Dr. Maves' ending slide as well. And now I hope we have a good discussion. And Katie, I'm handing it back to you.
Perfect. Thank you so much to both of you for those wonderful presentations. I'd like to go ahead and start off with what I think the million or $100 million question is here, and that's are rapid antibiotics and antimicrobial stewardship at odds with each other?
I say no. I say they're dependent on one another.
Yeah, I mean, I think the one makes the other necessary, right?
Mm-hmm.
And even though we are, kind of informally on opposite sides of this debate, just like Dr. Simpson said, I don't think there's any actual, if you followed us around at the bedside, you would not see a dramatic difference in our practices, other than me watching Steve and trying to imitate him to the greatest extent possible.
I was going to say, other than you being smarter at which antibiotic to actually choose.
But I think that actually does pivot into an interesting question. What's a broad spectrum antibiotic? And that definition, I think, was one of the points of contention between IDSA, SECM, ESICM, and in earlier iterations of the surviving sepsis guidelines. What is a broad spectrum antibiotic? Technically, ceftriaxone is a broad spectrum antibiotic. Mm-hmm. And if you are a 25-year-old community dwelling, basically immunocompetent adult coming in sepsis or septic shock, I would posit to you that there is an overwhelming likelihood that what you have is fundamentally a ceftriaxone deficiency disease. You have pneumococcus, meningococcal infection, some bowel catastrophe, group A strep, group B strep. Right, and then MRSA is the outlier, so we'll give vanc if the patient is in shock. Right, that is probably what you have. Now the question then becomes, well, how lucky do you feel? Right, there is a certain emergence of community-acquired ESBL infections, for example, for gram-negatives. Is it common in young immunocompetent community-dwelling adults? No. Does it happen? Yeah. So should we give cefepime instead? Should we give piptazo instead? Should we give a carbapenem instead? Or if we say we should use the broadest available drug, well, then everyone should be getting probably ceftazidime avibactam, right? Yeah. Well, we all kind of agree that that's too far. Like we're not going to be giving ceftaz avibactam empirically. But then why not? Why a carbapenem in that setting? And I think that is where a lot of the heat comes. Is no one, and I'm a critical care physician, but I am still practicing consultative ID when I'm not in the unit. And I think that source of tension is hard, and that has to be really driven by local antibiograms. Around here, your odds are better with cefepime for anti-pseudomonal coverage here in North Carolina than they are with the carbapenem up front.
Wow.
Right? But that may not be true everywhere. In fact, I posit that it is not true everywhere.
Right.
and figuring out. So I think it goes back to just like with Dr. Simpson's first slide about the road rash, is how lucky do you feel, or rather, what's your risk tolerance? You know, and if you have someone who is eyes are open, talking to you, has a non-embarrassing blood pressure, maybe you can afford to make your broad spectrum therapy a little bit narrower, depending on their epidemiological risks. And someone who's coming from a nursing home with a blood pressure of, 70 over nothing, you have no such leeway, and you have to drop the bomb on it. In that setting, I posit that the role of stewardship is not what you do in the first 48 hours, it's what you do after that.
Yeah, I don't disagree with a word of that.
I think those are great points, and I'd like to use that to springboard into sort of an adjacent space, right? So one of the limitations, if you will, of a lot of the sepsis literature is that it focuses on community-acquired sepsis and patients coming into the emergency department. But I wonder if you both might walk us through your approach to antibiotics in a patient who's been in the hospital for 5 days and is deteriorating, and you don't know, is this due to sepsis? Is this clinical deterioration due to other causes? And they're certainly at risk for more of those resistant organisms and other healthcare acquired pathogens.
Should the amateur go first? I'll go first so Dr. Maves can tell me where I'm wrong. But no, after, as you well know, after someone's been in the hospital for 48 hours or thereabouts, we tend to believe that new infections, if we believe it's a new infection, are hospital acquired, and you are bound to have to cover most of them with coverage for MRSA and for Pseudomonas. So you've got to be more careful. So even the 20-something-year-old who came in with a motorbike accident, who suddenly has fevers and mental status change 72 hours into the course, you've got to still cover that person because we have such nasty stuff outside. As far as diagnosing those people, that is very difficult. I think, Dr. Pendleton, you well know, and you have published in this area, that people tend to forget that this could be a new infection. And I think that's one of the places where we have room for improvement in the hospital, because, yes, you cannot treat every patient that develops a fever in the hospital. But I would posit that you do need to evaluate them a little more carefully, because we clearly miss those cases a lot of the time, and we delay the antibiotics in those people much more than we do in people who come into the emergency room.
Yeah.
Right?
Yeah, I mean, absolutely. It's for me, I would say one of the first thing I'm looking at is physiologic parameters in addition to the new fever, right? But obviously the microbiology is radically different, and that will depend very much on where you're coming from. Once you've been in the hospital for 72 hours, we've inoculated your bowel with enough Pseudomonas that narrower spectrum coverage is clearly no longer appropriate. Although still a lot of those do turn out in the future to be, susceptible, gram negatives or staph or things of that sort. But
yeah, they do.
Up front, that's not a bet you can take. I do like to remind people, especially in the reasonably stable patient, to look for other things. Look for DVT. In the intubated patient who can't talk to you, look for things like gout, other things that can sneak up on you, and you're really only going to identify by a good physical exam. That's just a kind of a standard observation. But yeah, otherwise, I couldn't agree with Dr. Simpson more that the story completely changes after the first few days. And a particularly dramatic example of that are patients who develop sepsis after a major burn. And the microbiology of burn units. That gets even more challenging because the physiology of a severe burn looks so much like the physiology of sepsis that teasing that out is an entirely separate and especially challenging puzzle.
Sure. And then to move on to one thing that I think I heard both of you agree on, right, which is major opportunity for compromises in terms of when we can stop or narrow antibiotics. Bearing in mind that, it's like 50% or less cases of sepsis actually have positive cultures to help guide you How do you both approach stopping or narrowing antibiotics in these patients?
Mm-hmm. Yeah, Ryan, why don't you go first last time?
I mean, I started a couple of kind of core things I think of that. There are two things I do believe in microbiology, that if Staph aureus is present, Staph aureus will grow. And if Staph aureus doesn't grow, Staph aureus probably isn't there. And so vancomycin de-escalation after 48 hours of negative cultures is one of the first places I start. I mean, you have to kind of define your syndrome, first of all, right? That even if we don't have a positive culture, we usually have some idea of where in the body it is coming from. And so my duration of therapy in a patient who is hopefully improving on therapy is going to be based on whatever I think their syndrome is, be it urinary, be it abdominal, be it pneumonia, or what have you. Early vancomycin de-escalation. I think with the advent of MRSA PCRs, we've done a good job of rapidly de-escalating people off of vancomycin based on MRSA PCRs, and some of the multiplex respiratory panels have also been helpful in that regard, getting us quick identification of causes of pneumonia. But yeah, 48 hours of negative cultures or a negative compatible molecular test getting vanc off. The other thing I believe is Pseudomonas. Generally, if Pseudomonas is present, Pseudomonas will grow, and if it doesn't grow, it's probably not there. Now that gets a little trickier because with Pseudomonas, we have so many other resistant gram-negatives, and I think when a lot of us, like when the three of us say Pseudomonas, we're kind of shorthanding it for drug-resistant nosocomial gram-negative rods. Right. So the absence of Pseudomonas doesn't help me de-escalate to quite the same extent. But getting vanc off is a big step. The other things that I think about in the truly culture negative one is having some idea of the microbiology of my unit, just knowing what are the odds. If I don't know what it is, it will probably be something that fits into this box. Biomarkers are the thing that we're all kind of hoping for to see if we can find that there is good data to support procalcitonin-guided discontinuation of antibiotics, not initiation, but discontinuation in a protocolized manner. I will occasionally use that to satisfy myself after a reasonable duration of 5 to 7 days of therapy in a patient who's getting better. I might grab a pre and post procal to satisfy myself that, okay, I think I can emotionally stop this. And that's based, I think, on some reasonably good RCT data. The problem is that there are too many confounders to procal to really let us breathe completely easily based on that. AKI, CKD, and ESRD, candidemia gives you a procal. All of those things. So if we take those into account, that's a general approach. That's a very broad one. But all of this is in the context of clinical improvement. And the patient who's not improving, I'm reluctant to take that approach. And the only, again, kind of hard rule I have is, well, if nothing grew, I could at least stop the vanc.
Right.
And Dr. Simpson, I'm just curious what you think.
Yeah, that's about the same approach I take. I would like to know, I feel very comfortable at 72 hours on stopping the vanc. If you got data about 48, I'd love to know about it, because I would really rather stop at 48 if I can.
That's a rule of thumb. That's not a law of physics.
Yeah. It's but my lie is if I don't see it by 72 hours, the vanc is gone without.
Very sensible.
With pneumonias, we are paying attention to our nasal swabs and our MRSA screens, and if that comes back negative, then we often get them back in an hour or two. Then I'm off the vanc immediately for sure.
There's a couple small interesting observational studies looking at the predictive power of nasal PCR screening for intra-abdominal sepsis. Actually, that it may have some correlation. I don't think the data is quite as strong, but I have to admit that I've used it as an excuse to stop vanc.
I'll buy it. The MRSA has to come, or the Staph aureus has to come from somewhere. And it probably originated up here.
Great. I think it seems like we're coming up on time here. So I was wondering if either of you had any parting remarks that you wanted to make before we sign off.
I do have something that's real important. I think we need to dwell on, and that is because I emphasized in the talk, and we haven't gotten to it yet. And that is that one of the tough things to do is to decide whether infection is present or not. The Surviving Sepsis campaign, and literally I was responsible for one of the responsible parties for the section on that graph that Ryan showed, is okay, if there's shock and infection is anywhere in the differential, great. If there's not shock, but you have clear evidence of infection, antibiotics. It's when you're not clear on antibiotic or on infection that antibiotics, where we said, okay, maybe you can put the brakes on this. So just to remind people that the original sepsis definition promoted by Roger Bone actually didn't say what it came to be over time, which was suspected infection. Suspected infection. That's what we said. What they said was evidence of an infected organ, but you don't have to have microbiological proof to start, right? So the first thing I want people to remember is go back to your first principles that you learned in physical diagnosis and ask yourself, what are the signs and symptoms of pneumonia, pyelonephritis, cellulitis, meningitis, and go through it systematically that way. Then the second thing that I want to say is we actually have diagnostic aids now that are available on the market and FDA approved for helping us to discern in those difficult to discern cases. One is the monocyte distribution width, which comes on CBCs. One is the IntelliCept by Cytovale, which looks at distensibility or squishability of neutrophils, and one is called the Septicite Rapid, which actually looks at gene expression for host response genes to bacterial infection. All of those are on the market. They are purchasable. They can help you in those hard to discern cases, and they all come back in, the IntelliCept comes back in 10 minutes, the Septicite in an hour, and the MDW comes on the CBC you sent, so however long that took. So they all are rapid and can help you come down for the high probability infection side and know to give your antibiotics rapidly sooner, and vice versa. There is a low risk of infection group on all of those tests.
Yeah, absolutely. I think the talk about biomarkers is interesting. You know, I've become a little bit of a biomarker nihilist in the last few years, but actually I am very, very excited about the possibilities of monocyte distribution width, particularly because that is, you know, it's on that differential. That is a thing that could become available in especially low resource settings, where getting another machine for another assay would be challenging. And we're actually going to be looking at MDWs and discriminative power and cardiogenic shock versus bacteriemic septic shock here, hopefully soon, as just an observational study.
Yep.
So, yeah, and concurrently with that is going to be improved rapid pathogen microbiologic diagnostics, pathogen directed.
Yes,
so, you know, the multiplex PCRs from whole blood have not perhaps panned out as well as we might have hoped, but there's some very exciting work looking at things like next generation sequencing of cell-free DNA, for example, which potentially could be, there's a very cool observational series from Germany that looked at the impact of that on therapy in patients with abdominal sepsis. And that could be the thing, the holy grail, or at least some variant of the holy grail to help rapidly identify pathogens and then narrow our therapy more quickly than we're able to do now. So, yeah.
Thanks both. I think those are great points, right? Going back to something that I think was in both of your presentations that we all agree on, right, is the delay to shock recognition is critical, and anything that we can do to help move the needle forward on that is going to get people earlier antibiotics and also help improve their outcomes. So it sounds like we have a lot of exciting stuff to look forward to in the future. All right. Anything else that we should talk about?
I'm sure there's plenty, but they're going to give us the hook pretty soon.
Yeah, I figured as much. Okay. Well, all right. Well, thank you, Dr. Simpson and Maves, very much for your time. This was a great discussion, and thanks everybody for sharing part of your day with us.
Well, thank you all so much. Take care.
Thanks a bunch.
All right, that's a wrap.
They can wrap it there, and yeah,
There you go.
cut that however you think, John. And possibly, since we went over a little bit, I suppose you can give little snippets here and there. And
I was actually thinking halfway through, there's a nice, the presentation and then the debate is a very kind of distinct two sections. So we might be able to break that up and kind of like be able to like bounce between those.
Yeah.
And so I'm gonna ask our editing team what they think. But some thoughts.
That'd be an interesting way to do it. Set them side by side and say, okay, here's the presentations, here's what was said afterwards. Yeah, that'd be cool. Katie, nice job.
Thank you. Okay, first one done.
Thank you so much.
Yep, exactly. Well, thank you all for staying on and give us and apologies.
This interfered with my lunchtime that I was promised. No, I'm just kidding.
12:07. It's still lunchtime.
True.
Yeah, that's a fact.
Yeah. Well, it was a ton of fun. Thanks, guys. That was great.
That was a ton of fun. I enjoyed the heck out of that.
Absolutely.
Thanks. Mm-hmm.
Well, everyone have a lovely weekend.
Thanks.
Thank you also.
All right. Talk to y'all soon.
We'll see you soon.
Take care. Bye.
Yeah.